co-invented some products. None of them will be highlighted during this talk. So I always like to start with something with dance. So here's my dancer, the Broadway dancer, who is showing us a grand plie, going onto the ball of the foot. And what she's doing in this deep grand plie is she's dorsiflexing the toes. And you can see that the toes are parallel to the ground and the metatarsals are perpendicular, and that creates a tremendous shear stress. And think about that shear stress when we squat, when we run, when we jump, when we lean forward, when we lunge. These are shear stresses that go on the MTP joints. And I would suggest that these shear stresses are responsible for a lot of the wear and tear pathology that we see in the toes. So in the dancer, it's part of the art, it's part of the aesthetic, but there's also the mechanical aspect that does drive pathology. During the releve, or even during a grand plie, the stresses tend to center around the second and third MTP joint. And this is from a pedographic study we did back in the days at Union with Francis McGuigan, who's on faculty at Georgetown. But this shows that the stresses really are concentrated at that second and third MTP joint, which is why we tend to see a lot of subluxations, dislocations, deviations at those joints. So keep that in mind, and I think that drives a lot of the pathology. These are some of the maps from the dancers we studied. These were Goucher dancers that were doing a pedobarographic mapping of the releve. So with lesser MTP joint problems, we could have some pain, we could have some swelling, we get some deviations, you get some subluxations. With time, you could get dislocations, but sometimes people come in with dislocations to begin with. You could get clawing or hammering of the toes, and eventually you could get arthritis, or sometimes, again, people will manifest with arthritis to begin with. On physical exam, you may get a floating toe, as you saw in the picture before, or you may have some synovitis at the MTP joint, and that's classically tender at the dorsal aspect of the MTP joint. You could have some pain underneath the metatarsal head, or a plantar keratotic lesion as well, where there's thickened tissue, hyperkeratotic tissue. You can have a tip of the toe that has some callus on it as well if you have a clawed toe, especially as the toe deviates and subluxates, it flexes down and can be driven into the ground and create a callus. On physical exam, you could have a drawer sign where you're causing a subluxation, and here I am doing a subluxation of the MTP, and you see just by pulling it up, can you guys see that? Yeah, by pulling it up, by dorsally translating, you can see the base of the proximal phalanx kind of protruding as I do that. Even my gentle pressure on the MTP joints alone tended to shift this toe dorsally, but certainly that subluxation maneuver caused the translation and subluxation of the toe. This is some x-ray findings that I thought were really cool. These were two colleagues of mine from the Netherlands, and they gave me this photo of the x-rays. You can see the second MTP joint where you see this increased space between the second metatarsal head and base of the proximal phalanx, and you could look at that relative to the space at the third, fourth, and fifth. And that was some subluxation of the MTP due to a plantar plate attenuation. Also on x-rays, we look for MTP deformities, you look for dislocations, look for Freiberg's or arthritic changes at the MTP as a result of a vascular necrosis or a stress fracture and bony changes. You can look for full-out arthritis. You should also think about the mechanics of that foot. What's the relative length of the metatarsals? If they had prior surgery, their cascade could be disrupted, and they may have a protruding metatarsal that can be appreciated in this plane. Also look for associated pathologies like hallux valgus. And here's a case, and you can see this young patient was having quite significant MTP synovitis. And you could see on this third metatarsal head that there is some deformity. It's less of a height or length of this metatarsal from the physis distally relative to the second and fourth. You can see that that third is quite short, and there's some sclerosis. There's a little bit of a osteophytic hook there, and that is indicative of early Freiberg's. And you can see here, this young dancer has some impaction already with the metatarsal head being distorted dorsally there. Here's a stress radiograph took from fluoroscopy of one of the cases. I'm subluxing the third MTP joint, and you can see that it's coming out of the socket, which should not be the case. Although there are some people who are a bit hypermobile, they should not go this far out of the socket. This is an MRI that I got from Caio Neri, a colleague in Brazil who does a lot of research and on the plantar plate, and has also been one of the pioneers of fixing the plantar plate. And here you could see the flexor digitorum longus tendon underneath the toe, and you see the plantar plate here, and you see a complete disruption between the plantar plate and the base of the proximal phalanx. Now, I would tell you that this is a very legitimate MRI, but you have to be careful, because in the area where the FDL comes right underneath the toe, there is a thinning of the plate that is natural, because it's an area where the anatomy is allowing for the passage and tracking of the tendon. So in the big toe underneath the MTP joint where the FHL is, you will see a thinning of the plantar plate normally at the first MTP joint. Less so in the second, third, fourth, and fifth, but just beware. You have to see it on a few cuts to know for sure that it's truly a plantar plate tear versus a local attenuation or thinning of the plantar plate in that area. And here you can see some synovitis around the MTP. You see a little bit of a change in the collateral ligament here, consistent with the plantar plate tear. You also have to think about the other pathology radiographically. Obviously, a case like this, you know, you're not just looking at the x-rays of the MTP joints that are affected directly. You should be looking at the big toe, look for whether they have midfoot injury, midfoot arthritis, and other problems. I like to look at this MTP joint syndrome as in this following fashion. Stage 1A, it's early. They just have pain. Their MTP joint is painful. They have some capsulitis or synovitis. They have strain of that joint, some wear and tear of the ligaments, wear and tear of the plantar plate, maybe some mild tendinitis, no deformity, mild swelling, stable joint. That's stage 1A, and this is something that I just use for my own thought process. I've not published this or anything. I just use this in my own thoughts. And stage 1B, this is also early. They have pain, no deformity, mild swelling. But the difference in 1B is that you have a subluxatable joint, so the joint can be translated proximally. And then we have stage 2, and this is where you have a deformity. So stage 1, you don't have a